Well, I am Anna Osland. I'm the Director of Research here at the Blanco Public Policy Center, and we are excited to welcome you to our Whole Health Louisiana Lunch and Learn today. Whole Health Louisiana is a collaborative effort led by the Louisiana Department of Health as the public sector anchor and the funder for the Whole Health Louisiana initiative. The Blanco Center leads the plan's implementation and evaluation. If you're unfamiliar with what Whole Health Louisiana is, it's the state's cross-sector initiative intended to systematically address, mitigate, and prevent childhood adversity within our systems of care and support. Whole Health Louisiana has four priority areas and goals: collaboration, awareness, workforce, and prevention and healing. With these priorities in mind, Whole Health Louisiana's vision is to build a state where children, families, and community members across Louisiana are healthy and thriving, regardless of who they are or where they live. All right, I'm going to turn it over to Quinn, who will be the moderator for today's session and introduce our speakers.
I'm Quinn. I am a research associate here at the Blanco Center. And today is our last Lunch and Learn that is hosted by the Blanco Center, not the last Lunch and Learn for the Whole Health Louisiana project overall. So we're so excited today to kick it off with Tara Lark. So as you guys know, we're holding a variety of different activities meant to raise awareness and deepen conversation about trauma-informed care practices. And our virtual Lunch and Learn series touches on the workforce priority area of the Whole Health Louisiana plan and features presentations from industry professionals and subject matter experts. Before I introduce our speaker for today, I want to first mention and thank our ASL interpreter for today, Lisa Gill. You should see her pinned to your screen to view the interpretation throughout today's webinar. In addition, if you are attending for CEU credits, please remember to complete the pro survey to receive your credits. Okay, and with that, I'm going to introduce Tara Lark, who is our speaker for today. She has earned her master's degree in counselor education from the University of New Orleans in 2015, and she began her career at a charter school in New Orleans where she served as a counselor and behavior intervention coordinator. She later joined a nonprofit organization in the New Orleans area where she developed and led mental health programming for fatherless boys aged 10 to 18. In this role, she also collaborated closely with the education team, advocating for students' educational rights and support services. Tara has brought this passion for student advocacy and educator support to her current role at the Louisiana Autism Spectrum and Related Disabilities Project. In her current role, she works in schools across the state, partnering with special education teachers to strengthen practices and improve outcomes for students with disabilities. With that, I'll hand it over to Tara to begin her presentation. Thank you so much, Tara.
Okay, as Quinn mentioned, today we're going to talk about, excuse me, trauma-informed care for individuals with disabilities, understanding experiences and improving best practices. I'm going to often look to over my right shoulder because my notes are on my second screen. So if you see me not looking directly at the camera, that is why. Okay, so as part of my work, for those of you who may not be familiar with LASARD, we are a project within the Human Development Center at LSU Health Sciences Center in New Orleans. The Human Development Center, or HDC, is Louisiana's University Center for Excellence in Developmental Disability, or its UCED, and it's one of 68 in the continental U.S. and its territories. This nationwide network is a resource for addressing and finding solutions to issues that impact people with disabilities and their families through technical assistance, module information disseminations, and research. Okay, I'm going to skip this slide because we've already introduced me. So today, you guys should be able to, participants should be able to learn the different types of trauma and understand its prevalence. Gain understanding of the effects of trauma as it impacts those with intellectual developmental disabilities. Learn the value of a trauma-informed care approach and what it looks like in practice. And just a disclaimer, this training is educational in nature and does not constitute diagnosis, treatment, or clinical supervision. Participants are encouraged to practice within their professional scope and licensing requirements. So first, I'm going to share this video.
In the mid-90s, the CDC and Kaiser Permanente discovered an exposure that dramatically increased the risk for 7 out of 10 of the leading causes of death in the United States. In high doses, it affects brain development, the immune system, hormonal systems, and even the way our DNA is read and transcribed. Folks who are exposed in very high doses have triple the lifetime risk of heart disease and lung cancer, and a 20-year difference in life expectancy. And yet doctors today are not trained in routine screening or treatment. Now, the exposure I'm talking about is not a pesticide or a packaging chemical. It's childhood trauma. Okay, what kind of trauma am I talking about here? I'm not talking about failing a test or losing a basketball game. I am talking about threats that are so severe or pervasive that they literally get under our skin and change our physiology. Things like abuse or neglect, or growing up with a parent who struggles with mental illness or substance dependence. Now, for a long time, I viewed these things in the way I was trained to view them, either as a social problem, refer to social services, or as a mental health problem, refer to mental health services. And then something happened to make me rethink my entire approach. When I finished my residency, I wanted to go someplace where I felt really needed, someplace where I could make a difference. So I came to work for California Pacific Medical Center, one of the best private hospitals in Northern California, and together we opened a clinic in Bayview Hunters Point, one of the poorest, most underserved neighborhoods in San Francisco. Now, prior to that point, there had been only one pediatrician in all of Bayview to serve more than 10,000 children. So we hung a shingle, and we were able to provide top quality care regardless of ability to pay. It was so cool. We targeted the typical health disparities: access to care, immunization rates, asthma hospitalization rates, and we hit all of our numbers. We felt very proud of ourselves. But then I started noticing a disturbing trend. A lot of kids were being referred to me for ADHD, or attention deficit hyperactivity disorder. But when I actually did a thorough history and physical, what I found was that for most of my patients, I couldn't make a diagnosis of ADHD. Most of the kids I was seeing had experienced such severe trauma that it felt like something else was going on. Somehow, I was missing something important. Now, before I did my residency, I did a master's degree in public health. And one of the things that they teach you in public health school is that if you're a doctor and you see 100 kids that all drink from the same well, and 98 of them develop diarrhea, you can go ahead and write that prescription for dose after dose after dose of antibiotics, or you can walk over and say, what the hell is in this well? So I began reading everything that I could get my hands on about how exposure to adversity affects the developing brains and bodies of children. And then one day, my colleague walked into my office and he said, "Dr. Burke, have you seen this?" In his hand was a copy of a research study called the Adverse Childhood Experiences Study. That day changed my clinical practice and ultimately my career.
Okay, so I just wanted to present that video to you guys as a guiding video for what we're going to talk about next. So we're going to begin talking a little bit about, we're going to start talking, provide some background on the different types of trauma experiences, and then discuss how you would support clients or patients within your care who have a trauma history and who also may present with a form of a disability. So this is the Adverse Childhood Experiences Questionnaire. This is what you give what you do is you give yourself a check mark for all the things that you've experienced prior to your 18th birthday. Individuals with four or more ACEs were 2 times more likely to smoke, 7 times more likely to misuse alcohol, 10 times more likely to inject illicit drugs, and 12 times more likely to attempt suicide. The life expectancy among populations with six or more ACEs is 19 years shorter than that of populations with none. So some pretty compelling information about the impact of ACEs. So they're successful traumatic events that occur between the ages of 0 and 17. They make it more difficult for a child to succeed in school and live a healthy life, and they're toxic to brain development and can compromise its structural integrity. Data show that approximately 61% of adults experience at least one ACE, nearly 25% of adults experience three or more. In 2016, it was estimated that 46% of youth experienced at least one traumatic event. But who experiences them more? Certain groups are experiencing trauma or ACEs, not that they're interchangeable, at higher rates, including individuals who identify as Black, Hispanic, or multiracial, those with incomes of less than $15,000 per year, and those who are unemployed. So what does the data say about ACEs in children with developmental disabilities? Children with developmental disabilities, particular autism spectrum disorder, are at increased risk for ACEs. The most frequent ACEs are bullying at 3 to 4 times higher rates than their neurotypical peers. Identifying ACEs in a child with ASD or other developmental disorders is complicated by the diagnostic overshadowing, which is a tendency to attribute symptoms or behaviors to an underlying condition rather than the environment or other medical conditions. So in Louisiana, the issue of childhood diversity and trauma is especially salient. Louisiana ranks 49th among all U.S. states in terms of overall child well-being. Louisiana is the third highest in terms of number of children per capita with two or more ACEs. Next, we're going to talk about intergenerational trauma, I'm sorry. Okay. Epigenetics. Research suggests trauma may influence gene expression through epigenetic mechanisms alongside environmental, relational, and social factors. The traumas do not cause a genetic change, but do alter how the gene functions. The alteration is an epigenetic change. The epigenetic change alters how your body reads the DNA sequence. So here's an example for maternal stress during pregnancy. A pregnant individual experiences chronic stress, for example, poverty, unsafe housing, or exposure to violence. What happens biologically? The body releases stress hormones like cortisol. These hormones can cross the placenta and influence the developing fetus. Instead of changing the baby's DNA itself, they change how certain genes are turned on or off. This is epigenetics. Then the long-term effects can be seen in the child. There's a more sensitive stress response, easily triggered by fight or flight, increased risk for anxiety, depression, or behavioral challenges, and greater reactivity to environmental stressors later in life. A 2018 study found that the male children of Civil War prisoners of war were more likely to die soon after the age of 45 than people whose fathers had not been POWs. Paternal stress could affect future generations through epigenetic channels. In addition to epigenetics, the transmission of trauma might be influenced by cultural, psychological, or socioeconomic factors. So let's sum it up with parenting versus epigenetics. Kids whose parents experience trauma are more likely to grow up with a parent who is unstable, emotionally distant, or anxious. Those parenting behaviors may also contribute to trauma that is passed down to another generation. Epigenetic influences may be demonstrating the body's attempts to prepare offspring for challenges similar to those encountered by their parents. At the school that I worked at, we had a class of students who behaviorally, which you know likely links to an emotional component, were the most challenging group that we worked with than any other grade in the school. Every teacher quit after teaching them, and sadly, many quit while teaching them. In their third grade year, they went through 6 different classroom teachers. The one link we discovered that they all had in common was that they were all in utero or born through Hurricane Katrina and its aftermath. That connection becomes invaluable when planning to support that class. Unfortunately, the same class were middle schoolers for the COVID-19 pandemic, and we know which is also a critical time for development. I was no longer working at the school during the pandemic, so I can't elaborate on how we saw the situation continue to play out, but it is important to note that. But there's good news. Some of these stress-related intergenerational changes may be reversible. Several years ago, it was discovered that combat veterans with PTSD who benefited from psychotherapy showed changes in their DNA. The findings confirm that healing is also reflected in epigenetics. So, this does not mean trauma is destiny, but it does mean early environments and interventions matter deeply. Healing environments can help reset stress systems. Trauma informed care can literally support biological recovery, not just emotional healing. And just sharing this food for thought, I thought it was a compelling quote. What is learned in the cradle is carried to the grave. Next, we're going to talk about the social determinants of health. These are the conditions and the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life, outcome, and risks. So, though healthcare is essential to health, research shows that health outcomes are driven by many factors. The main categories are economic stability, neighborhood and physical environment, education, food, community safety, and social context, and our healthcare system. So I'm going to give an example about how a social determinant health matters. Food access in the lower Ninth Ward of New Orleans. It's a community without a grocery store. The lower Ninth Ward has not had a full service grocery store in decades, especially since Hurricane Katrina. The residents rely on convenience stores, gas stations, limited small markets. This creates a long-standing food desert. Why does the problem persist? Well, there's zoning restrictions, which limit large grocery stores from opening, economic challenges, smaller population, less incentive for investment. There's a high land vacancy. Approximately 54% of the area is vacant land. According to a 2023 report from the data center, the lower Ninth Ward had more than 2,400 vacant residential lots in 2023, which is 70% of all residential land in that neighborhood. So there's limited food infrastructure. Approximately 2% of the land is used for food business. So the business environment lends to it being easier to open gas stations than grocery stores. Why does this matter? It's limited access to fresh, nutritious food. It's increased barriers to healthy living, greater risk for chronic health conditions. Access to food is a key social determinant of health. For further perspective, and we know there are many factors that are involved in these statistics, the life expectancy of the lower Ninth Ward, and this is only a pocket of the lower Ninth Ward, as other pockets reported no data according to this map that I was looking at from the data center. So the life expectancy is 66 years old. The life expectancy of Chalmette, a city just across the canal from the lower Ninth Ward, is 74 years old. Next, we're going to talk about weathering. So what could it be? In 2020, the overall life expectancy in the US dropped by 1.5 years, largely due to the COVID-19 pandemic. Native American people lost an average of 4.5 years of life expectancy, and Black and Hispanic people lost, on average, 3 years, while white people lost only 1.2 years. Why do you think this is the case? It's attributed to something called weathering. The term weathering was coined in 1992 by Dr. Arline Geronimus. Weathering describes the effect of racism and classism on the body. Marginalized people suffer nearly constant stress from living with poverty and discrimination, which damages their bodies at the cellular level and leads to increasingly serious health problems over time. While studying trends in women's fertility, Dr. Geronimus had observed that African American women do not have the same prime childbearing years as their white counterparts. Namely, an average white woman is considered to have the most fertility and the lowest risk of unhealthy pregnancy and neonatal mortality when she is between 20 and early 30 years old. However, for African American women, this peak of fertility and point of their lowest risk was in their teens. In other words, Black women in the United States were more likely to have a healthy pregnancy in their late teens than in their mid-20s. Dr. Geronimus then first advanced the weathering hypothesis as a potential explanation for these maternal and infant health disparities. So, in summary, understanding trauma and its impact. Trauma is common and can affect lifelong behavior and development. There's higher exposure among marginalized communities, low-income populations, and individuals with an intellectual or developmental disability. Trauma is shaped by social determinants of health, chronic stress, weathering, and intergenerational influences. So, how can trauma manifest in neurotypical individuals? Invasive thoughts, acting out behavior, depression, loss of sleep or appetite, being stuck, or living in fight, flight, freeze, or fawn. How does trauma and intellectual and developmental disabilities? What we know about this. Traumatic experiences may occur at different points in time. Traumatic experiences may occur after the IDD diagnosis. So, for example, a child with IDD who sexually abuses a teen, that could be the traumatic experience. Traumatic experiences and their treatments may cause a disability. So, for example, a traumatic brain injury that is a result of a car accident. Individuals with IDD are more likely to experience stressors such as neighborhood violence or parental incarceration, 3 to 4 times more likely to experience adverse events such as abuse, neglect, and medical trauma, face a greater risk of experiencing adverse events, and are at a higher risk of developing stress disorders after the events. Continue to talk about their risk exposures. More caregivers across the lifespan increases risk of exposure to abuse and neglect. This is partly due to deficits in adaptive living skills that make people with IDD reliant on others for care. Communication difficulties increase the likelihood of experiencing abuse and neglect when people are unable to report on abuse or neglect in a timely manner, if at all. IDD and communication. We consistently teach that humans behave in a way to access, gain, or avoid or escape. For individuals with IDD, this approach is presumptuous at best. Often behavior is an expression of an emotion rather than a manipulative effort, as communication may be limited. Attempts to communicate traumatic experiences may be seen as a behavior challenge related to the disability. If the provider only tries to manage the behavior, it could exacerbate the trauma response. In those with very limited communication, distress may be signaled by the exacerbation of an old behavior or presentation of a new behavior. In attributing challenging behavior solely to the disability, opportunities for trauma recovery are missed. Okay, so what, and now what? What? Traumatic events, whether inherited or experienced, likely live in all of us. So what? We must provide trauma-informed care that actively avoids re-traumatizing. Now what? You will learn about the 6 principles of a trauma-informed approach. The CDC Center for Preparedness and Response, in collaboration with the Substance Abuse Mental Health Services Administration, led a training on 6 guiding principles that guide a trauma-informed approach to increase responder awareness during a public health emergency. While we may not be in one official public health emergency at the moment, all of the aforementioned types of trauma can collectively be considered a public health emergency. The 6 principles are safety, trustworthiness, and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and cultural, historical, and gender issues. The final portion of this presentation will provide tips on how to have a trauma-informed approach with all patients or clients, and particularly those with a disability. So first is safety. When thinking about safety, consider all ages, cultures, races, demographics of the people served. Have an awareness of physical, emotional, and interpersonal safety. Consider what would be thought of as a trauma reminder and work to reduce them. We must ask people what safety means to them. If we don't challenge our own worldview, assumptions, and life experiences regarding what safety means to us, we will not be able to ensure a sense of safety for all, but simply be creating safety for people like us. We must ensure that we create safety for those who have different experiences from our own. We must also be able to maintain emotional regulation, allowing those we serve to feel safe and knowing we will be who we say we are. So when you consider an example of what might be a trauma reminder for some, but may not be for others, is having an armed guard working at the door of a school or facility. Law enforcement may not make all members that you serve feel safe. So how can this look in general in practice? Greet patients warmly and explain what will happen during the visit. First, we'll talk, then I'll check your vitals. and you compare this with a first then visual for those who may need further reinforcement. Offer choices about seating. Would you like the door open or closed? Where would you like to sit? Avoid sudden touch and always ask before physical exams. Keep the environment calm. Ask about lighting preferences, noise, privacy, etc. How can this look when supporting individuals with disabilities? Use predictable routines and visual schedules for individuals who benefit from structure. For example, a client or a patient with autism. Adjust the environment, dim the lights, reduce noise, allow sensory tools. Respect personal space, mobility devices, and communication devices. Prepare before transitions. For example, in 2 minutes, we will clean up and move to the next activity. Another example is before a medical exam, you could show the tools, model on a doll, and let the person touch all the tools first to become familiar with them. What happens if safety has been compromised? In a school setting, this may look like a fight between students. In a clinic setting, this could be witnessing a patient in distress. How can you recover and reassure that safety is a priority? We tend to not address things such as a fight at a school or a patient in distress, as we want to protect the privacy of those directly involved while also tending to those directly involved. We can forget that those peripherally involved also have their sense of safety violated. What are some things you can do to address the bystanders and assure them that their safety is still a priority? When working at a school, I found that most of the issues happen between students when we were short-staffed. As an example, how to address this would be to ensure areas like the cafeteria and recess have as many people on hands as possible. In a clinic setting, perhaps it's a robocall, text, or portal message providing resources to follow up in case any patients or clients feel in distress following the experience. So just taking a minute, let's reflect. What will safety look like for you in your practice? Consider physical, emotional, and interpersonal safety. What does this mean for all? Okay, next we'll talk about trustworthiness and transparency. This is operations and decisions must be made with transparency at the forefront. Everything matters from a simple, warm smile when you greet someone to approaching conflict in safe and respectful ways. Admit when a mistake has been made and make the effort to repair. How can this look when supporting individuals with disabilities? Use clear, concrete language, avoid idioms or vague phrasing, explain steps before they happen and stick to the plan, use visual supports or social stories to preview new experiences, be honest about changes. The schedule is different today, here's what will happen instead. As in a clinical example, I'm going to take your blood pressure, it will squeeze your arm for about 10 seconds, then stop. What does this look like in practice? How will you consider both your client and their families when reflecting on trustworthiness and transparency? Some ways you can do this are being honest about wait list, legal limitations such as mandatory reporting or obligations, or any changes within your practice that may affect your patients or students. As a personal example, my mom passed away 15 years ago from cancer, and she was treated by an oncologist with whom she developed a trustworthy and caring relationship with. When the chemo days became extremely difficult, my mom was growing weary. It was her oncologist who had encouraged her to continue her fight. After one chemo treatment my mom received at MD Anderson, we received a letter in the mail that her oncologist had retired effective immediately due to a family matter that had arisen. Subsequently, and likely ironically, I don't want to fully attribute this, my mom passed away less than 2 months later while in remission. While I don't believe this is due to the fault of any medical profession at all, I do think that her trust was broken with her healthcare provider, and her health was too critical for another provider to take much needed time to build rapport. Okay, the next one is peer support. Utilizing lived experience to foster hope, trust, and recovery. So, peer support assists in establishing safety and trust and promoting recovery and healing. In a classroom setting, it looks like building intentional conversation, student to student and adult to a student. In a clinical setting, it looks like connecting with a client on a shared experience, creating a sense of belonging and removing isolation. So, what will this look like in your practice? What are some ways that you have experienced support in your life? To reflect further on my mom's experience for a treatment at MD Anderson, they would have former patients sit in the waiting room and wait with you as you waited for your appointments, and they wore name tags that shared how many years in remission they were. It was nice to have someone's lived experience serve as a source of comfort, and furthermore, in this instance, it demonstrated that hope to a cancer patient, that perhaps one day they may be sharing their story in that lobby as well. Okay, the next one is collaboration and mutuality. Leveling power differences and promoting partnership between staff and service participants. Support staff and stakeholders to reflect and attend to their own well being. Collaborate with other support systems in clients' lives. Allow clients to weigh in on decisions about their care by offering choices in accessible ways, using pictures, AAC devices, yes no cards. Allow students to weigh in on decisions in the classroom. Observe behavior as communication and respond based on what the person is showing you. These steps can greatly increase the sense of collaboration and mutuality. So, what might this look like in your practice? And how does it feel when you are included in decisions made that will affect you? Okay. The next one is empowerment, voice, and choice. Believe in the possibility, believe in the possibility of recovery from trauma. Provide choices. Many people with past trauma or who also are experiencing a disability have experienced coercion or people making decisions for them. Therefore, choice is critical. Solicit feedback and act upon it. Respect a patient's no in whatever form they're able to tell it to you. Offer choices whenever possible, appointment times, treatment options. Highlight strengths and not just deficits. Adapting the growth mindset and assuming people are not the sum of their trauma. That acting out behavior isn't always because they may have thought about their lost family member. Perhaps they may be hungry, tired, or in pain. Allow the space to assume resilience is possible. Perhaps a family member shares with you that a certain medication that is taken in the morning that is taken in the evening makes them tired. Fly their chart to prioritize morning appointments for them. We know that reimbursements from insurance companies and for IEPs, individualized education plans, work from a place of demonstrating a need, therefore highlighting deficits. Make sure you highlight patient strengths too. Empowerment, voice, and choice. What does it look like? Let's reflect. What will empowerment, voice, and choice look like in your practice? And when have you felt seen or heard by a healthcare provider? And finally, cultural, historical, and gender issues. Address discrimination, promote equity, and practice cultural affirmation. Be aware of, and wherever appropriate, acknowledge your own implicit biases, privileges, and power. Be aware of ableism and past negative experiences, for example, being restrained, excluded, or misunderstood. Understand that family and cultural values affect how a person responds and reacts to trauma. A patient who has experienced trauma avoids direct eye contact, speaks very little, this is an example, I'm sorry, and speaks very little and brings several family members to their appointments. A clinician unfamiliar with the patient's cultural background might interpret this as a lack of engagement or dependence on others. A trauma-informed clinician recognizes that family involvement may be a significant source of support in decision making. Past experiences with healthcare systems may affect trust, and trauma and cultural norms may influence communication styles. And lastly, use identity affirming language. Ask preferences. Identity versus person first. So, for example, a person with autism or an autistic person. Putting it to practice, cultural, historical, and gender issues. Let's reflect. How will you demonstrate an understanding of issues surrounding equity, anti-biasness, and cultural affirmation in your practice? And do you have opportunities to engage in courageous conversations around these sensitive topics? And we would be remiss not to discuss something that all providers feel, may feel at some point in their career, which is compassion fatigue. And it's the mental and emotional fatigue that you may feel after continual exposure to others' traumas. It's characterized by feeling numb, feelings of helplessness and sadness, excessive ruminating or worrying, and feeling cynical, apathetic, or unable to empathize. what can you do? You can take a break for the day, or you can also take a break from your practice for the time that you may need if it helps you become the provider that you need to become or need to actualize on. Set limits, stick to a daily routine. Predictability is beneficial for all of us. And think of what else that you know that is best for you when you are experiencing that compassion fatigue. And finally, if your role is not a mental health professional, yet you find yourself in a therapeutic role with your clients, reset boundaries. Remind them of the providers in their life who can provide that therapeutic service, who can provide those therapeutic services for them. Okay. In summary, traumatic experiences lie in all of us. We must approach those we serve through a trauma-informed lens to prevent further traumatization. While helping others is at the forefront of what we do, we must also remember to take care of ourselves. You can't pour from an empty well. Okay, that is it for me. Thank you so much. This is a survey that I have as part of my organization, and I believe you guys, or you mentioned that you guys send one out as well, right? Is that correct?
Yes, that's correct.
Okay. Do you want to, are you okay if they take a minute to complete this one and then we'll do the Q&A?
Yeah, that's totally fine.
Okay.
Sarah, that was really interesting. If you think about, could you tell us a little bit more about thinking about that from both either a parent standpoint, if they have friends whose kids have disability, like if their friends have siblings with disabilities, and thinking about that from like the standpoint of others that are, thinking about it a slightly different, aligned with that, but how we can be supportive. Or also thinking about it from like a parent and you know that your kids are in school with kids, but it's not maybe, it's aligned within the same classroom. Talk to us a little bit about that from like outsiders' perspectives.
Yeah, absolutely. So inclusive practices is something that the organization I work for, Lassard, is very much promotes the inclusion of these students with disabilities with their peers. And a lot of times I think that we, think it's taboo for for the kids to ask questions about their peers, like, why are they in a wheelchair? Why do they, so, sometimes kids with autism will stim or do some vocal stems or physical stems where they may flap their hands. And I think for the longest time, learning about this was taboo. It was taboo to ask the questions to the people, right? Like we don't want to ask, don't ask, just be quiet and we'll talk about it later. But sometimes it is okay to ask. Sometimes it is okay. Why do they do that? And the more you educate yourself, and as long as you're teaching the appropriate ways to ask these questions and the appropriate, and to always be a source of always coming from a place of concern and care because you're asking because you want to be able to support, not because you want to be nosy or want to be judgmental. You are genuinely asking what it is about this person that has them, engaging in these types of behaviors or has them using a wheelchair or has them using, a paraprofessional in the classroom. And what is it that you can do as their peer to help them in the classroom setting? And I think as long as you're coming from that genuine place of, I just want to be able to help, then I think the person on the other end can perceive your question asking and provide you with some of those ways as well.
I think that's really I like that thought a lot. So when I had little kids, my kids are pretty big now, but when they were little, like early elementary school, there was a child that had just a different ability. And I looked for like picture books to help talk about
Mhm.
that and process that with one of my children. And so I think thinking about from like a parenting standpoint, like how to be supportive and how to teach your child to ask those supportive questions is a great way of thinking about it. So
And reduces shame in it. If you're asking the questions and you're answering the questions, talking about it in your homes, talking about it with your kids, then it teaches them that it's okay to talk about. There's nothing wrong with for any of the needs that these people have or what, like you said, their different abilities. There's nothing wrong with them. They just need different things than what we might need.
that's really great. As we're thinking about it also from the standpoint of community members, how can we be helpful and supportive, integrative within the community and in the different organizations and businesses that our diverse Whole Health Louisiana membership represents?
Yeah, I would encourage you to think about the spaces you find yourself in. I can give you an example that we went to the Children's Museum, the Louisiana Children's Museum here in New Orleans, and we have a great collaboration with them, so I feel comfortable sharing this. And when we walked around it, we realized how much of it was not accessible to kids who are not neurotypical. And I don't think the people who created the museum had that lens when creating it, when modeling it. So they had, the different different food things for it's very open play, very open concept play. And that sometimes is just too big or too vague. And so we encourage them to use task analyses of the different things you can do within this space. Communication boards, the different, ways you can ask questions about what's going on in that space. So that's just one example. If you think of the different places you visit in your life and you just sort of start thinking about, like, I have young kids and I'm at the pediatrician's office, thankfully not as much anymore, but I was a lot, when they were little. And I had started this job when one of mine were little and realized that, there was nothing in my pediatrician's office for a kid who could not, if a kid could not verbally, if a kid was old enough to should be able to verbally communicate but couldn't, there was no means to subsidize that. The parent was speaking for them. And so we provided communication boards. My colleague and I, both of our kids were at this pediatrician office and provided them with communicate what's wrong communication boards. Just like a general task analysis of what you can expect when you go to the pediatrician's office. I did the same thing for my dentist office the other day. I was there and she was mentioning they were starting to see kids. It's an adults only pediatric dentist that's changing over to pediatrics as well. And I asked her what they had for kids, with any kind of cognitive developmental disabilities, and she was very transparent. She's like, nothing. Please send us whatever you have. So we sent social stories to them about, like, what does going to the dentist look like? What? So just like think of the spaces you're in, and just kind of start looking around and think of, could every person who comes here truly be served by this space? And if not, what can I recommend? How can I happen? Actually, the Children's Museum, to their credit, has a ton of accessibility options on their website that you could print or view before you go, but not everybody knows that. Not everybody thinks to think, like, let me check the website before I go to the museum.
Is there some kind of audit tool that organizations can use to help think that through? Because, like, for example, if you're an organization and you're switching, like your dentist is to serve a different demographic, is there something that they could pull down and say, okay, let's think about how we do this better so that we serve everyone? Have you seen anything like that?
I have not, but I wouldn't be. Let me, if you don't mind, let me ask my team. One of my colleagues who I just mentioned, her son is 10 years old, I believe, and he has autism, and he was a driving force behind a lot of changes that she made personally in, like, all the place. So let me ask, please, if you don't mind. I'd be happy to email, and if not, I'd be happy to create one because it is something that I think is super important.
Okay, yeah, that'd be really cool. Yeah, and we'll certainly share that back out with folks if we get something from you, but that's really interesting.
Yeah, absolutely. I would love to make sure I find something.
Okay, yeah, cool. And look, I saw some questions are in the chat, so I'll let Quinn ask those ones.
We have two questions so far in the Q&A box, Tara. So I'm gonna go ahead and read the first one to you. It's from Claudia, and she asked, as Louisiana's rate of disability is higher than the national average, how can Louisiana strengthen the systems, services, and policies that support people with disabilities?
Um, it is in our local and state politics. It is definitely in what is being proposed. I think sometimes, to be transparent, what I'm learning in my current job, there's sometimes those would appear to be smaller measures on a ballot that end up cutting funding to your school system to provide the support within the school system. We're experiencing it in the current landscape for next school year, some millages that didn't pass that had been proposed that would have enhanced services that the school was able to provide. So just paying more attention to what is going on. I think if you think about it, just think, and I'm going to speak from a child perspective, at the end of the day, a child spends majority of their waking hours in the school environment and however that may look. So I like to always kind of come at it from that school environment and how do we strengthen the system that they spend majority of their waking hours in. And so it could be, as whoever your role is in that school, whether it is teacher or clinician, or I'm not sure what Claudia, what your role is, but whatever your role is, parent, asking questions about how this, questions about how students with disabilities are serviced at the school, asking more about how you can support, asking, it is to your point, the diagnosis specifically of autism, I think in 4 years jumped from, I'm not gonna don't I'm not 100% certain on this, but it went from 1 in 54 to 1 in 31 within 2 years. So the reality is that these children or these people are around us every day. And I think it's educating ourselves on how we can be allies of support for these individuals so that they can be themselves in the places in which they are operating every single day.
Our next question is, out of what you presented, what do you think are the most important principles organizations should follow when implementing trauma-informed care for individuals with disabilities? And what are some examples of organizations that are doing this work particularly well?
Hmm. Examples of organizations that are doing. It's tough because I think it would be more of an advocacy type organization that would, and I can't think of any off the top of my head, not that they don't exist, but I think would often, it's often, I'm trying to think of who would probably be doing it. Like school, I know I keep kind of resorting to the school example, but it's school systems who are supporting these students. So, ABA clinics that are supporting individuals with autism. I think the societies related to the disability are often the ones doing the work to get their needs and wants to the forefront of us, right? So I think how they infuse it with trauma informed, I don't think you find it very often. I think it's sort of having to marry the two worlds and having to have that clinical mindset of what more can this be? I think just like and what else is this? What else could be going on with this child? What else should I dig deeper in when when they're presenting to me? Am I getting the holistic presenting picture? Am I asking, if they mentioned they have a therapist, am I collaborating with the therapist to provide the right type of support that this client may need? Do I know their trauma history? And what was the first part of the question? I'm sorry, I kind of jumped in straight to the back end without addressing the first part.
You're fine. The first part was, what do you think are the most important principles organizations should follow when implementing trauma-informed care for individuals with disabilities?
I think that guiding principle in that ACEs slide that you can assume at least everybody has an experience. It said 62% of people have experienced at least one or more, at least one ACE. I think assuming I think the statistic on the slide was from 2016. I had tried to find more recent data and didn't succeed in finding some credentialed recent data or some valid recent data in my opinion. But I think operating under the assumption that trauma does exist in everyone, and sometimes the diagnosis alone is the trauma, right? So if you're the parent of a kid who learns of this child's diagnosis, or if the diagnosis happens from a brain injury or something like that, that is its own level of trauma, accepting the diagnosis as a parent, right? Like it's understanding that that is an experience in and of itself. So I think I don't know how often the two are fused within systems that we're in. I think it's a mindset shift we have to start implementing in the systems that we are in ourselves.
Tara, our next question is, where do you see the greatest gaps in professional training related to trauma-informed care and disabilities?
I think the greatest gap is in the therapeutic services. I can tell you in graduate school, when I went to school to be a mental health professional, we never discussed how to provide counseling services to a person with a disability who may need extra accommodations of sort, who may not be able to participate in traditional talk therapy, who may not be able to tell their story, themselves in the way that they know it to be. And so, in my opinion, the gap is very much within the training that I know I received. And I haven't, I haven't gone back to school and taken classes in a minute, but I don't find when I go within school systems and interact with school counselors, I find that the gap that they identify, the gap is still there. Not realizing, training with AAC devices. Sometimes kids, a lot of kids who can't verbally communicate through an augmentative communication device. That is not something just the average person knows how to pick up and use, right? Like And if you think about it, I mean, when you go to the grocery store, you're more likely to be able to communicate on your iPad than you are through sign language because a lot of time you have to, the person on the other end has to be fluent in sign language. So there's a societal gap in the ways in which people are communicating that are not the traditional ways we know it to be. So even like thinking about the grocery as an example, how does a person who can't verbally communicate at the grocery get all the support they need in doing their grocery shopping? And they may not need it, but thinking about the ones who may need some support. How are our systems and places designed to support, holistically support all people entering that grocery?
Thank you for that answer. Let's see. I see that there's something in the chat. So there is a question from another question. Are there emerging trends or innovations in trauma-informed care for people with disabilities or otherwise that you're particularly excited about?
Um, I think and I don't mean to reduce it, but I think simply the awareness around that 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 the behavior is it could be a trauma presentation. I think the awareness I think we are just drawing awareness in totality to to what the experience lived experiences of a person with disability. So a lot these we were talking about kids who were educated in completely different buildings to now within the same school buildings, hopefully in the same classrooms as their peers were appropriate. And so we're talking about how, we're seeing a societal evolution on where these children interact every single day. And so just putting them in the classroom setting that we're putting them in the building and saying, hey, they're here isn't enough. And so it is building more awareness to, and I'm sorry, the question was which trend are we aware of in supporting kids who've experienced trauma and have a disability, right? That was the question, right? Yeah, so I think it is the awareness piece alone, I think is the current trend, is just the idea that, where I saw the other day somebody asked where can a kid in a wheelchair couldn't go to their community pool anymore because the community pool didn't have a lift to get the kid in the pool. And so it is I think awareness is the trend that we have to really be on board with. And I think we're in a world with social media, that is where all the information is. We know that. We know if it's on TikTok, it's the gospel according to the youth. So how do you use what is at hand and teach the people around us about what is going on with individuals with disabilities?
Tara, for your answer. And I think that was our last question. Um, so I just want to wrap up and say thank you everybody for attending. Thank you to our speakers. And sorry, there's something just popped up in the Q&A. Um, Nanette, I don't think that for this round of Lunch and Learn for today, we are not offering LPC credits. Oh, we are offering LPC credit. Okay, sorry, I apologize. We are offering LPC nursing and social work credits for today's webinar. I think the survey just needs to be updated to reflect that. So if you give us a couple minutes, we can handle that. Thank you so much for bringing that to our attention. Does anyone else have any other questions about today's presentation or the survey? Okay. Um, Again, thank you everybody. Do remember to complete the CEU survey, but again, we're gonna edit it real quick to make sure that LPC is an option for those who are seeking LPC credits. Tara, thank you so much for your presentation. And if there's anything that you would like me to send out to the attendees from your presentation, if that's just additional information, resources, websites, things like that, just let me know and I'll be happy to share those resources out to everybody here. And yeah, I think that's all the announcements I have for
Yeah,
today. Again,
and
thank
I
you.
just thought of one thing.
Yeah,
Our
go ahead.
website is lasard.org, LASARD.org, and there's a resources tab on it that has a bunch of different visuals that are free that you are welcome to print off and bring to any environment, any environment that you're in that you think they'd be beneficial. And if you don't see something on there, like a communication board for the dentist or the doctor, something that you have in mind, please. My email was at the last slide. It's tlark at LSU. I think I can put it in the chat. Please feel free to email me. If it's not on our website, doesn't mean it hasn't been created. We service schools across the state, so it could have very well been created for a school, and it's just not on our website. So as you're thinking of the environment you're in, if you want more resources and you're like, hey, does this exist already? Please email me. I'd be happy to create resources or present to you what we already have on hand.
You, Tara. And then my colleague dropped the link to Tara's organization in the chat as well as her email. If anyone who is interested in asking more questions, you can reach out directly to Tara. And I think that is everything for today. Again, thank you everybody for attending. Next month's webinar will be presented by Tony Bankston, who will discuss retention, resilience, and recovery, whole health strategies for health and mental health professionals. Thank you to our interpreter as well. Alyssa Gill, thank you so much for all the work that you have done for all of our webinars. Thank you, everybody, and have a great week and stay dry out there in the weather.